On behalf of the American Heart Association, I would like to welcome you to today's webinar, Cardiovascular Implantable Electronic Device Infections, Incidence, Impact, and Gap in Care. My name is Eddie Pan. I am a Quality Program Manager for the American Heart Association. Today's webinar is made possible with support from Philips Image Guided Therapy. I'd like to begin by going over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most users' issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you will receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit questions for our presenters at any time using the question sections of the control panel. We will collect your questions and address them during the Q&A sessions at the end of today's presentation. Now, it is my pleasure to introduce our speakers for today, Dr. Bruce Wilkoff and Dr. Arnold Greenspon. Dr. Wilkoff is the Director of Cardiac Pacing and Tachyarrhythmia Devices and a staff cardiologist at Cleveland Clinic. He is a professor of medicine at Cleveland Clinic, Lerner College of Medicine, and at Case Western Reserve University. Dr. Wilkoff is also the chair of the CIED Infection Summit Planning Committee. Dr. Arnold Greenspon is a professor in medicine and the Director of Cardiac Electrophysiology Laboratory at Jefferson University Hospitals. Dr. Greenspon has had extensive experience with cardiac implantable electronic device procedures and developing strategies to reduce device-related complications, including infection. Dr. Wilkoff, the floor is yours.
Thank you so very much, and welcome to our the beginning of our National CIED Infection Initiative, which we'll talk about a great deal. These are my disclosures. And as you can see, that I have been involved with various of the people from around the industry for a while, but we are trying to make sure that everything has greater value. So I am having some difficulty advancing my slides, in case somebody can help me. There we go. So there's an American Heart Association National CIED Infection Initiative. And the problem we're trying to solve is that, although not an epidemic, it's certainly not uncommon that patients with a CIED, or a cardiac implantable electronic device, can develop an infection after implantation. And as a consequence, infection is also associated with increased mortality and can prevent patients from receiving full quality and quantity of life benefits. So we're here to raise awareness and to help people, particularly our patients, get the care that they need. In 2017, the American Heart Association developed a scientific statement along with the Heart Rhythm Society, which was an expert consensus statement on cardiac implantable electronic device lead management and extraction. And fully half of this is related to infection. And we're here to talk about the infection part of this document and the ability to get this information out to the community. The initiative, that of the National CIED Infection Initiative, is to address the gaps in awareness, detection, and appropriate treatment of CIED infections through this summit. So we convened a summit to solve the problems of the public health burden of CIED infections, reduce quality and quantity of life, the complexity of CIED infections, and the healthcare burden that this provides. And the goal was to provide actionable solutions. So we convened an interdisciplinary medical professional panel, and we created a plan to disseminate tailored education to healthcare professionals. And so this is part of that initiative. This is one of the first parts in trying to make people more aware and understand the magnitude of our problem and how we might address it. Here's a look at some of the people that were at the summit. It was convened on March 25th, and there were more than 40 key stakeholders from around the country and indeed around the world, representing patients as well as physicians, regulators, and administrators from every level, and certainly our nurses. We also created a logo here, Treat to Beat CIED Infection, that you're going to see on most of these slides. That's our Twitter handle. A little long, but it gets our point across. So I'm going to first introduce this, and then Dr. Greenspon's going to go into greater detail. So what is a cardiac implantable electronic device infection? Well, it's a bacterial, yeast, or fungal infection that forms on a cardiovascular implantable electronic device. When we're talking about that, we're talking about pacemakers, defibrillators, and CRT therapy. And it can either be an infection in the pocket that is introduced at the time of the surgery, so contamination from the skin and the air around, or it can be contaminated from a metastatic infection from inside the body, from an infection that occurred from a bone or from the skin or from other abscess causing hematogenous seeding during an episode of bacteremia. In addition, when the CIED leads are implanted through the veins, clots form along the lead where it touches the vascular space. This is a composite photo from dogs, but the same thing happens in people. See the hit, skip, the clots, the scar tissue. And as time goes on, that fibrosis gets firmer, and sometimes it becomes calcified. And it's this substance that becomes infected often. What happens is you have a vein, we put the leads in, a little bit of clot forms, a little bit more clot forms. After a longer time, maybe some scar starts to form. And afterwards, now that lead is in place. Now, how does the infection manifest itself? Well, it's very variable and extremely variable. So here's an example of a little bit of cellulitis, it looks like. You really don't know what's underneath the skin. But obviously, this could be self-limited, or if this persists, this certainly could be an infection. Now, here you see the dimpling of the skin. You'd see a little bit of erythema. This dimpling is part of what's called fat necrosis. So the adipose tissue underneath the skin is eaten away by the bacteria slowly, and it causes a dimpling. This is clearly an infection. Nobody's going to argue that this erosion is related to an infection. The erosion, the leads come through the skin, and even though that you're not seeing pus, that eating away, that slow eating away, and ultimately seeing the leads can be the manifestation. Now, this is an aggressive infection, almost a necrotizing type of infection. Nobody's going to send this patient home. Sometimes there will be an erosion, and often it's dry, not wet like this one. But when this occurs, clearly this is an infection. Sometimes there'll be a draining sinus, and you'll see some pus that will come out through the skin. Another time, if you look on the right, it's just a swollen area, but if you push on it, out comes the pus. Now, another time, you might see leads. This is a scanning electron micrograph of an implantable defibrillator lead, kind of pretty. But if we go in closer, we'll find out that the bacteria and white cells that are on the metal are inside the insulation. And this patient presented just with positive blood cultures. No pus in the pocket, no vegetations on the leads, but just these bacteria inside the lead. I like to call it lead juice because when I put a stylet down it, little drops come out. And if you culture them, they're isolated from the bloodstream. There's no way that antibiotics or time will get rid of this infection. Now, this is a less subtle infection. You'll see it over the next few slides. You see this sort of looks like we're going to do a delivery here. As this lead comes out, you see it's attached to a very large vegetation. And when we take it out and put it on the table, this is the vegetation that was on this lead. Now, this is unusual and obviously not what you would hope for, but that it can happen that way. Now here's another example of the endocarditis that can be attached to a lead. And you'll notice that the endocarditis is not just on the lead, but goes onto the endothelial surface of the inside of the atrium. Now, often people think they can get rid of these infections by just burying them deeper. And this is the consequences of burying this one deeper. And you can see these abscesses as they erode through the skin. Or in fact, not just the infection, but the leads themselves find themselves on the outside of the body. This exteriorization is what happens if you leave it alone, if the person survives that long. So you've now seen a number of ways that infections can present. Well, when does the infection start? Let's look at this 90-year-old man with a history of coronary artery disease, ischemic cardiomyopathy. He had his implantable defibrillator implanted in 2003. He developed a complete heart block in 2011, and an atrial lead was added. And then in 2015, he was upgraded to a CRT-D with a CS implantation. But in 2016, he developed an infection. So he's been part of the Denominator for 13 years, from 2003 to 2016. If somebody was looking at 3 months, 6 months, and 1 year infection rates at their center, it would be 0. 0 at 2003, 0 at 2011, 0 up to 2015. Now, the point is that this person developed an infection. Here's a look at it. You see the dimpling in the top, and then it progressed towards erosion on the bottom. But the point is, you might not recognize this infection, but this infection was brewing for a long time. And certainly if you look at the time of discharge for an infection, or a month later, or even 3 months later, that's not long enough to pick up most of these infections. So they start a long time. And in fact, when we looked at a large population of over 800 patients, we found out about 25% of the patients presented in the first month, about a third of the patients presented in the rest of the first year, and then a full 40%, well 42% in this case, presented over a year from the last operation, with convincing information that suggested it was from the time of the last surgery. So how do we know about this pocket infestation? Well, we've gained some insights from a trial of the Tyrex antibiotic envelope. It was presented in the New England Journal of Medicine. So we'll just talk about this a little bit from this data. It's the largest implantable device trial ever done. Almost 7,000 patients, 25 countries, 181 centers, 776 implanters, as you can see in the world map here, a very large trial. Now, it provides information about how to prevent infections, but it also tells us a lot about those infections. And the intervention here was to try to prevent the infections during device changes or upgrades. The device was taken out, new device put on, the envelope put in, the envelope goes into the pocket with the device. You sew up the device and the pocket, and then over the next week to 10 days, antibiotics, 2 antibiotics, come out into the tissues. And then over the next 3 months, the envelope dissolves. Now, this was the intervention, and we compared the infection rates in these two conditions. And over 3 years, the primary endpoint was at 12 months, but this is the data out to 3 years. We showed that the native infection rate was 1.9% at 3 years. And it was reduced by a full 40% overall and 50% for pocket infections. Now, what kind of bacteria are infections? This is another investigation that we did of patients coming for infection. And this shows you that 68% of the patients in this study were by staphylococcal infections. And that's by far the most common bacteria that causes this. About half being resistant and half being sensitive, half being coag negative, half being Staph aureus. And then you can see there's an assortment of other bacteria that are also included. But the most important thing about these staphylococcal infections is these staphylococci produce biofilm, which makes it very difficult, probably impossible, for the body to fight off the infection once it starts, and it protects the bacteria from the antibiotics. Here's another look. This is through the RAPID trial where we see here on days until systemic infection at the top and days until pocket infection on the bottom. But you'll see, broken down by any pathogen or Staph aureus, how long it is between the time of the surgery and when they manifest. So you got to be vigilant about this. You have to see that these infections present much later, not just within a few months of the time of surgery. And these have consequences. So depending upon how you look at mortality, from the time of randomization in the rapid trial, where mortality went from 18 to 25% with that, or from the onset of infection, where it went up to 23% infection rate from the time of 23% mortality after infection at 24 months. So these are important events, and they're lethal events. One of the other things that we found out from the rapid trial, that the risk of infection in patients who had a hematoma was 11 times higher, was up to 13%. So if you could know when there was going to be a hematoma, you would know that the patients were much more likely to have an infection. And in fact, if they had a hematoma and an envelope, that dramatically reduced the infection rate all the way back down to 2.5%, or about just twice as much instead of 11 times as much. The other thing that you should know is virtually all of our patients are on anticoagulation. In this study, 86% of the patients were on either anticoagulation or antiplatelets, with about 15% of the patients being on both. And depending on how you strategized using either the anticoagulation or the antiplatelets, you were much more likely to get a hematoma. And if you got a hematoma, you got those infections that we were talking about. And you can see that adding, in the dark blue, the antiplatelets to whatever strategy you had, no anticoagulation on the left, DOACs in the middle, or warfarin, if you had antiplatelets in addition to the anticoagulants, your hematoma risk was greatly increased. And of course, that means your infection rate was greatly increased. So this is an introduction. I just want to give you some key takeaways. Pacemakers, ICDs, cardiac resynchronization devices are very effective, life-saving, and generally safe devices, despite all the stuff I've been telling you. However, CIED infections can occur and can be difficult to detect and are dangerous. The best approach is prevention, and this is often possible, but early detection is important, possible, and can save lives. The treatment is extraction, complete removal of the entire system, and antibiotics. Not antibiotics or extraction or antibiotics. It's both together. And this is much safer than a delayed or untreated infection. Finally, we need every caregiver to help us with early detection. So I want to thank you for this opportunity and look forward to your questions in a little bit.
Thank you, Dr. Wilkoff. And next up, we have Dr. Greenspon. The floor is yours, Dr. Greenspon. Sorry, Dr. Greenspon, I think you are on mute.
Okay, we in business? Okay. Thank you everyone for your attention, and thanks to the American Heart Association for inviting me to speak today about a very important topic that you've heard about. And I hope to give you some understanding of the impact of cardiac implantable device infections, both in the way that you can recognize them, strategize in your patients, and hopefully help all of us understand the gaps that we have in the care of these patients. I need to be able to advance my slides. First, these are my disclosures. I was a consultant on the RAPID study where I was part of the events committee, and I've received some grant support from Medtronic. Let's start with the case. A 75-year-old man with non-ischemic cardiomyopathy, YQRS, had a CRT-D device implanted. He returns for elective device replacement due to pulse generator end of life. Several weeks later, the operative site is red, swollen, and he had received postoperative antibiotics. And he's referred for evaluation. And this is what it looked like. And everyone thinks, well, how can this happen? How can my patient get an infection? I never see infection. And the fact is, infection is rare. And as you will see, occurs in maybe 1% to 2% of patients. And we can only really learn about what's going on out there by looking at large databases, not your individual practice, where you may only see infection rarely. So I hope this talk, by looking at large databases, we get understanding what's going on out there, both in terms of device implantation and also infection. Learn a little bit about the types of infection and what is the appropriate treatment. And you've heard that. It's both antibiotics and removal, complete removal of the device, which often involves lead extraction. I'm going to talk a little bit about the costs. And those costs are both economic and human. We'll talk about the cost, the hospital cost, and what it costs to the healthcare system. But think about the cost to your patient, the patient that has to go to rehab, the patient that can't work, can't function. And you'll see that a patient who has an infection goes on a completely different survival curve. And finally, we'll talk about some of the gaps in care where you all can help us identify and treat these patients more promptly. So first, infection is not uncommon. If we look at infection complications following an operative procedure, we see that probably more than 60,000 patients a year will develop the device-related infection. If we look at what's going on there, I want you to pay your attention to this figure in the upper left-hand corner. And we looked at a large database with over 15 years of data from the nationwide inpatient sample. And you see, in terms of device implantation, overall device implantation in red is increasing. In blue, you see cardiac ICDs, which are increasing at a greater rate than the increase of pacemakers. And this is largely due to large clinical trials in the 1990s, which came out and showed that for primary prevention, ICDs save lives. So overall, CIED implantation is increasing, and ICDs are increasing at a greater rate than pacemakers. And today, ICDs represent about a half of all implants. If you look at the Mayo Clinic data there on the right, you see that with the advent of CRT, now we have about 40% of patients who have ICDs have a cardiac resynchronization device. Now, who are these patients? The patients are older, they're sicker, they have more comorbidities such as heart failure, and if they have CRTs, those devices don't last as long as pacemakers and ICDs. They require more procedures. What's happening with infection? If we look at the trends in infection over the number of years, we see that infections are increasing out of proportion to the increase in cardiac devices. So overall, CIED implantation is increasing, but the infection burden is increasing out of proportion to the increase in devices. So what's going on? There's an increasing infection burden, and that's largely due to an aging population and a group of patients that have more comorbidities. Here's our study from 2011 that looked at 15 years worth of data. And you can see that there are more patients with renal failure, heart failure, diabetes. Our patients are older, they're sicker, and they're getting more complicated devices. You'll see here from a study that type of device impacts the infection rate. So we have more CRTs with more leads, sicker patients. We have more CRTs than ICD infection and pacemaker infection. So the rate of infection is greater depending upon the complexity of the device. And with all these devices, the rate of infection continues to increase over time. We looked at a Medicare database from 3 years worth of data. This was presented at Heart Rhythm meeting in 2013. And what we were able to show by looking at a large database is that the risk of infection, not surprisingly, increases with age, comorbidities, and the complexity of the devices, as you've seen, but also with the number of revisions that a patient has. So it's not just additive. The second operation, the third operation, the fourth operation, the fifth operation, your risk for infection dramatically increases. So unlike a computer, when we talk about an upgrade, a simple procedure, no procedure in a patient with a cardiac device is a simple procedure, but requires an additional intervention. So if we can limit the number of interventions, perhaps we can reduce the amount of infection. We looked at this in a large database and looked at the difference of infection rate between the initial procedure and the device replacement procedure. And there are two things I want you to notice in this graph. First, that replacement infection is at least double. And as I showed you before, the number of procedures that you've had increases that risk. But notice that the slope of both curves do not flatten out. That is, over time, your infection rate continues. So it's not just in the first 30 or 60 days, as you see, where the infection rate is the highest, but over time, patients are at continued risk for infection. And there are two types of infection. We can classify them as local infection, which you can easily see is related to the surgery. That would be a pocket infection or generator erosion, as you've seen. But these patients have implanted hardware. So they're at risk during the duration of their life for lead-associated endocarditis or bacteremia, which would attach itself to the lead and cause a systemic infection. In a large database that we looked at through the Medicare Database, the multi-center device infection cohort, we showed that they were equally distributed. So patients could have local infection, could go on and develop a bacteremia in about 50-50. We looked at pocket infection. When we think about pocket of infection, we think of it as an operative infection. It should occur soon after surgery. And sure, it does happen. Most people who have pocket infection occurs early, within the first 12 months. But you'll notice, and as you've seen in the prior slides that Dr. Wilkoff showed you, patients can present days, months, years later with a pocket infection. And some of these patients will go on to develop systemic bacteremia. Well, why is that the case? Well, we don't know why in certain cases the bacteria in the pocket get activated, but if you culture pockets at the time of replacement surgery, you can often recover coagulated negative staph and other organisms, and somehow they may get activated. So the point is that infection can occur not just in the first 3 to 6 months, and it may explain why a strategy such as an envelope may be protective longer than that. In our cohort, we also looked at systemic infection, and I broke it down into early infection, which is within first 6 months, versus late infection. And systemic infection, as I said, can occur throughout the life of the patient once they have a device. And patients that had early infection, it was most often related to organisms that can be cultured in the pocket. But late, patients had all kinds of organisms, often due to hematogenous seeding from a distant site. So your patients who have hemodialysis, who have other operative infection, who have urologic procedures. We had a patient who had a renal stone and developed sepsis at seat of the lead. This could occur at any time following device implantation. And that points to strategies. Maybe some patients would be best suited for leadless systems or subcutaneous systems that don't involve implanted hardware. So what happens after you have an infection? Well, let's first look at the left-hand panel, which looks at a survival curve in patients with ICDs and CRT. And you can see that this is a sick group of patients. And if you look at 3 years, 4 years, or 5 years, not surprisingly, there's a fairly high mortality. But if you go to the right and you look at patients who've had a CIED infection, you see they're different survival curve. Survival of all patients in black gets moved up to the survival curve in blue, so that even if you survive that infection, you're on a different survival curve. And infection has lifelong consequences. It's also costly. This just shows you the cost involved. It's the hospital cost of an infection. We looked at a market scan database and found that whether or not you had an initial implant or a replacement, if you had an infection, the hospital cost was somewhere around $50,000. But this does not measure other things which I call indirect costs. The cost, of course, to the patient in terms of lost livelihood, the family members who have to take care for this patient, the rehabilitation costs, the drug costs. Infection is costly, and it's not just the initial hospitalization. So there is a treatment and there's an answer, and that's why we're having this webinar. The first thing is to try to recognize that your patient has an infection. and consult with an expert who is an expert in removal and treating the device. The guidelines, which are Class 1 guidelines, state that all hardware must be removed for either local or systemic infection. Prior to starting antibiotics, of course, we obtain blood cultures, but the important point here is that antibiotics alone do not cure a CIED infection. Now, despite these guidelines, we found that, at least 40% of patients are not treated appropriately, and we'll talk a little bit later about the gaps in treatment of these patients. So no matter how you look at it, what study you look at, it's quite clear that antibiotics alone will not cure infection, whether it's local pocket infection or systemic infection. Only removal, extraction, removal of all hardware will treat the patient. And device removal makes a difference over the lifetime of the patient. As I said, following an infection, they're on a different survival curve. But the survival curve of the patients who have extraction and removal is clearly much better. The other point I want to make is that when you perform the treatment matters, so that early detection and therapy is important. This study showed that the timing of extraction and removal influences outcome, whether it's a systemic infection on the left or a localized pocket infection on the right. If you perform early extraction, you've improved that survival curve, but if you delay it for even a week, the patient's on really a deadly curve, as you see here in the red. This is a recent study which was presented at the American College of Cardiology just a few months ago by Sean Corney from Duke, which was sponsored by Philips. And this data looked at over 1 million patients who received implantable devices. And it looked at the infection rate at 1, 2, and 5 years. And the infection rate over that course of time was about 1.1%. One can argue with the infection rate, but the important thing here is to look at how are these patients treated. And the striking finding was that only about 20% of these patients received an extraction within 30 days of the diagnosis. And if you look at the survival curve on the right, you see that if extraction was performed early, the patients in the lower curve clearly had the best outcome. If you delayed extraction more than a week, they had a worse outcome, and the patients who were first treated with antibiotics and delayed any kind of intervention clearly had the worst. So there's a large gap here in terms of identifying infection and getting patients promptly treated. And that treatment is not only in terms of, as I said, of mortality, but it's the cost. See here, this is our study of a Medicare database, and we looked at the time to device removal and the cost. And again, if you get those patients within 30 days, compare that to patients that you're waiting months until they get the treatment. There's a cost associated with device removal, even if the patient survives. And the treatment is to remove the lead with extraction. I want to show this slide because people often feel that lead extraction is a dangerous procedure. Well, what we want to get across is that infection is a dangerous diagnosis, and removal of the leads is actually a much safer procedure. The Lexicon study, which is one of the largest study of extraction, is almost 15 years old. And if we look at the safety of extraction, since the laser was introduced till 2009, we see that there's about a 1% procedural risk and an operative mortality of about 0.3%, which is actually lower now with modern tools. So the thought here is removal is actually a safe procedure, and getting your patient promptly treated is what's most important. The other point I want to make is that extraction is the kind of technique that requires experience. Here in the Lexicon trial, clearly showed that high volume centers had a much better outcome than low volume centers that do just a couple of cases a year. So the idea that we should hold on to our patient, treat them with a little antibiotics, see what happens, is not a good strategy. Or just, kind of wait until things get bad and then try to extract the patient. Can we predict infections? And let's look at some of the things that we can think about in our patients. First, there are things that are device related, there are patient related factors, and there are procedural related factors. In terms of device related factors, I pointed out that the more complicated the device, the higher the infection risk, which relates to more hardware, probably longer procedure time. The second thing is the type of procedure that you do. Again, system upgrades are not like computer upgrades. They require sometimes major procedures and time. What about patient factors? And we'll look at that in a moment, to look at factors in your patient which may present with infection. And finally, there are some procedural things that we can think about. First, all patients receive preoperative antibiotics, but operator experience, procedure duration, history of prior infection, hematoma, as you heard, are all important factors. The recent Canadian trial called PADIT tried to look at whether intensive antibiotics as compared to lower intensity of antibiotics would impact postoperative infection. And it was essentially a negative study in that it showed that there was no difference in outcome. But they were able to come up with a score to predict which of their patients went on to have infection, called the PADIT score. It's much like a CHADS-2-VASc score that we use for stroke risk in patients with atrial fibrillation. And you get points, just as you do with CHADS-2-VASc. For example, if you have a CRT, you get 4 points. If it's a revision or upgrade, you get 5 points, and so on. And then you put the point score together, and it gives you an idea of the risk for infection in your patient here from 0 points, low risk, and in the more points, the higher the risk. So we can use a risk score on our patient preoperatively, give us some idea, maybe that patient might be a candidate for a leadless pacing system or a non-thoracotomy system. And we validated the PADIT score with a group that I worked with in the Optum database. And it showed that if we apply the PADIT score to those over 50,000 patients, it helped predict which patients were at risk for infection. And in the insert were patients who had prior infection, and the PADIT score worked particularly well. So in my last couple minutes, a few final thoughts. Well, first, there are trends in CIED implantation infection. There's an increase in the number of implants. There are more CRTs and ICDs. These patients are older and they have more comorbidities, and they often have to go for more procedures, whether it's a system upgrade or devices that don't last as long as the pacemakers. So there's an increasing infection burden. Pay particular attention to the fact that repeat procedures are associated with higher risk. There are two types of infection. There's that localized pocket infection, and there's systemic infection. And the important thing is that infection is a lifelong risk. It's not just a postoperative risk. Infection carries a high mortality, and it puts you on a completely different survival curve. Infection's costly, not only in the cost to the hospital and the system, but the cost to the patient and the family. Delay affects outcome, and treatment involves both prompt identification and some of the prevention maneuvers that I talked about. And finally, there's significant gaps that I hope we can address to try to reduce this problem. Thank you for your attention.
Thank you so much to Dr. Wilkoff and Dr. Greenspon for leading today's webinar. It is now my pleasure to introduce our moderator for our Q&A, Renee Sednew, Senior Program Manager.
Thank you, Eddie, and thank you, Dr. Greenspon and Dr. Wilkoff. As we're waiting for a few more questions to come in, I'd like to begin with a few questions that were submitted by attendees during registration. So first, what infection prevention strategies or specific indications for the use of Tyrex envelopes exist? Dr. Wilkoff, would you like to take this one?
Certainly. There are certain things that we know reduce the rate of infection. We know that preoperative antibiotics are the cornerstone of infection prevention. Having probably a cephalosporin, if an allergic, vancomycin on board at the time of the incision is a keystone way of preventing infections. We know from the PADET study that adding extra things, washing out the pocket, prolonged antibiotics, such like that, is not important. Certainly, the basics of aseptic technique are very important. But beyond that, if you did those things, then the infection rate should be low. And the key is to measure your infection rate, to know what it is, because if your infection rates are higher, that means that there's been a breakdown in what's going on. The use of the antibiotic envelope has been shown to reduce infection rates approximately 50% in patients who have received those interventions. And if you are a patient at higher risk, such as the patients in the PADET score, as Dr. Greenspon was talking about, the envelope is clearly important. And as I mentioned, any patient who appears to be at an increased risk for a hematoma seems to be in a good situation there. But even if you did all these things, you're having infections, even if you don't think you're having infections. You're probably not picking them up. And that's the key, is to be able to observe your patients, follow them up, maybe take pictures of the pockets. There are things that you can do. There's things that your patients can do. There's some, just by examining the pocket and saying, is there something changing here? Because it's picking it up early that's the key. No matter what you do perioperatively, infections will occur. If you're not seeing them, you're not looking for them.
Thank you. Great. So the next question is the practice of pocket irrigation using antibiotic truly required? Dr. Greenspon, do you want to start this one?
So I think that's an excellent question. I think it points out there's a lot of things that we do in medicine that haven't been studied carefully. And I think it's good that we're performing studies like RAPID, and RAPID actually showed that a operative intervention made a difference. And it was done in a careful way. And it also highlighted the importance of pocket hematoma and how we probably should develop better strategies to reduce pocket hematoma. We haven't done that yet. We talk about the use of anticoagulation, interrupting it, antiplatelet drugs, the problem of patients on dual therapy and DOACs. I think that's other areas that can be studied. I was just involved in a study that came out of Vanderbilt where we looked at about 1,000 patients. There were 6 worldwide sites, and we did it in a randomized fashion. We randomized patients to antibiotic pocket wash. They all got an envelope. They were all high-risk patients. And like PADET, we showed there was no difference in infection. So I think a lot of things that we do in medicine, we do for historical reasons. You know, we've been doing this for years. We never see infection. And the point I make on one of my first slides is you don't see infection because it's not that common. You have to do 100 pacemakers to see one infection. So the only way we learn about this is large trials, looking at data, as Bruce suggested, that maybe compiling our own data and looking at what our own infection rates are, looking at our own operative techniques. I think that's important.
And there's a live question coming in that's related that I'm going to ask now. Is timing of antibiotic important? And either one of you, feel free to answer.
So as I mentioned, the quality metrics, and of course you've got to keep up with the quality metrics as well, suggest, and not just for CIED, but any operation, is to have antibiotics fully on board at the time of the incision. So timing of antibiotics is important and depends upon the antibiotic. If it's a cephalosporin, you can do it within an hour. It takes a couple of hours to get good vancomycin dose in. So it does matter. Preoperative and antibiotics on board at the time of the incision, but it's also clear that post-operative antibiotics are not of value.
Another point I also want to emphasize is the lifelong risk of infection. And I think people need to pay particular attention to people have prosthetic joints, they have other things going on, and our device patients have a lifetime risk. That joint gets infected, they get bacteremia, they have a device infection. So I think we have to kind of get the word out that this hardware that's in there gives them a lifelong risk. And anything we can do to reduce bacteremia will reduce infection.
Thank you. So here's one more. How do you define, it's a two-part question. How do you define denominator and numerator? Secondly, how do you define the time frame for which the infection is attributed to a procedure?
So most of the studies of infection are in fact patients who come to me. So for instance, I'm a lead extraction center. I've been treating infections in CIED patients for over 3 decades. And so patients come to me. The vast majority of those patients that have infections were not implanted at my center. So the denominator is very large. So that's not how you do numerator or denominator. The way you treat numerator and denominator for a study is that you prospectively enroll patients. That's the problem. Infections are low frequency events, so you have to prospectively enroll them over a large number of patients in order to be able to see. What I do at the Cleveland Clinic is that we keep track of every single surgery we do. Then we follow up and we look at infections at 30 days, 90 days, 6 months, and 1 year. Then after a year, we are less sure because there are other things that patient has had. They've had other surgeries, there are other things that are going to them, and so it becomes less clear you can attribute the infection to that particular initial event. So I think the first year, it would be best to be able to follow your patients. But the denominator is every single patient that has a CIED procedure. But you need to divide them. You have the patients who have the initial implant, you follow them. And that's probably your quality metric because those are the clean patients, the ones that will tell you about the quality of your infection prevention. And then you follow the patients where there's a device change, a lead addition, a lead extraction, so secondary procedures, and look at them separately. So we separately report our primary implants and our secondary procedures, and then look at those rates. And we look at them not because we're trying to slap our hands, but even the best center is going to have a breakdown in technique. You need to be kept on top of things because unless you look for them, unless you know about it, you won't know that you're having a problem.
That's a good answer.
Thank you, Dr. Wilkoff. And there's several excellent questions coming in. So for patients who are undergoing lead extraction due to infection or other issues, are these patients eligible for another implantation of the device?
Go ahead, Arnie.
Yeah, well, the short version is yes. The long version that both Bruce and I are laughing about is when do we decide to reimplant is the issue. And I think that's an unsettled, that's not a, we can't give you a scientific answer on that. We get different answers from different of our infectious disease colleagues. So the question is, the indication for the device still stands after the patient has the system extracted. The question is about when timing of reimplantation. Sometimes it's quite simple with a localized pocket infection. A few days later, you know, you're going to get it. But if the patient has systemic infection, it can be complex. And I think you'll get different answers. It has not been carefully studied. I don't know how to answer that better.
So the first thing is make sure that the person still has an indication for reimplantation, because about 15% of the people, the indication isn't as strong as it used to be or doesn't exist at all. And so if you can avoid it, you should. On the other hand, the patient who's pacemaker dependent and you've got to have something, then the question is more, how are we going to do it, and how are we going to tide them over? So now it appears that there's less risk from a leadless device. Maybe you're going to reduce the intensity of your CIED. Maybe you're going to use epicardial leads in this patient. Maybe you're going to choose to do this open surgical extraction to get rid of the vegetations so you can go back in and do transvenous. So before you take something out, spend 5 minutes and think about how you're going to go on from there, because it's extraction, antibiotics, and then what? You have to decide before you take it out, or you're going to go back afterwards. What's your strategy?
You know, I think Bruce brings up a good point, because the highest risk patients are those with prior infections. So I think all of us in this field are careful about the decision to who to reimplant and how.
Thank you. That's an excellent discussion. So the next one, would measurement of CRP or ESR be helpful to identify earlier? And the second part of that question is fever seen early in the course of infection?
You know, I started looking at this intensely in the 90s, and we started looking at all these patients. And first thing was, when did they present? And I presented some of that data. The other thing was, what symptoms did they have? And they had all sorts of symptoms. They did have fever. They did have white cells. They did have sed rates. They did have all these things, but none of them haven't had them in a majority of cases. So unless you're looking at all of the things, you're looking at the whole picture of it, you don't know. So you can do sed rates, but it's too non-specific. You can do things, different scans and everything else like that. You have to, what I've come down to looking at is looking at symptoms and seeing patients back, taking pictures. That's the modern thing that I think is so spectacular. Now we have the ability to put pictures in our electronic medical records. You take a picture today, you take a picture 3 months from now, 6 months from now, a year from now. If it's different, there's a problem. And these things can be very slowly growing. So it's a matter of index of suspicion, unexplained symptoms. It could be pain, fevers, white counts, chills, and such like that. But generally speaking, it's nothing. It just slowly progresses.
Hey, the only other point I want to bring up, Bruce, we like you, we want to engage the patient without scaring them, not frightening them. But we engage the patient. They take a picture of their own pocket, and we paste that into the Epic record. And the next person that comes along, we're able to review that. So I think that's an important thing. Also, to engage our primary physicians. You know, they'll see the patient, take a picture, put it in the record, and so on. And now that we're doing more and more remote monitoring, this is just part of the way of remotely following patients. And in fact, at our summit, we brought up strategies. I don't know if you were, I think you were there, Bruce, at our meeting. We were talking about patient-related strategies to get some of this information into the record, to be helpful to get earlier detection, because that's part of the game, I think. Patient awareness, primary care being part of this picture as well.
Engaging the patients, primary care, the nurses, the administration, because it's going to save everybody money, time, pain, suffering, and mortality.
And that's an excellent segue to our next question. I think we have time for one more, and then I have a wrap-up question. What is the role for the patient in terms of education or warning? And I know this can be a long answer, but a few of highlights of your thoughts. Dr. Wilkoff, go ahead.
Right. So it's really, they're part of the team. I can't see a patient unless they come back to see me. And when I talk to the patients, and I'd love to see every single one of them, and I see a lot of them. We follow 60,000 or so in our device clinic. That's a lot of people, but it's not everybody. And the fact is, I only see the ones that come back to me. On the other hand, it's up to the patient to be their best advocate, their own best advocate. So they need to be followed, not just because of the possibility of infection, but device therapy is dynamic. there can be improvements. There can be programming, other things. So it's important that the patients say, come back to their doctors and they are followed, be followed. The same thing is true for the cardiologist, the internist, everybody else that sees them. He said, listen, every once in a while, you need to go back and have somebody take a look at this a little bit more. Stay in touch. I like to see my patients once a year, but the most important stuff is that you don't lose touch, and stay informed. I mean, the patient has to be their own best advocate.
So I think to sort of sum it up here, I mean, we're talking about an initiative. And part of the initiative, as we get into remote monitoring and people aren't coming back to the office as much, we had COVID, people, all those kind of things. We need to engage our patients, our nurses, and our referring physicians. And so at the outset, the patient has to be educated about what this device is all about. They tend to be elderly. We got to get their families involved. And I think that will go a long way to helping identify early detection, keeping patients and the families engaged in the whole process. Again, infection is a lifelong risk. And so when they go on and they're going to have another procedure, they have to understand that we have to do everything to minimize bacteremia and infection. I think this is all part of the initiative.
Something that everybody should be aware of is every time something crosses a patient's skin, it's a risk. So if they're a dialysis patient, every week when they get dialyzed, that's a risk. If they have an orthopedic procedure, that's a risk. If they have an IV in the hospital, that's a risk. Now, not huge risks, but the fact is, if you see an infectious disease doctor, you say, I have a defibrillator. Or you see a dialysis patient, and you're a dialysis doctor, say, I have a pacemaker over here. Or if you're getting a catheter put in for your cancer treatment, and say, oh, I have a pacemaker too. So bring it up with your doctors. They have to be aware, they need help. Come talk to somebody that deals with it all the time. But it's everybody's job, not just one person's job.
Thank you. And in our final minute here for the questions, we have a diverse group of healthcare professionals in our audience today, which is wonderful. So I'd like to hear from both of you just briefly, what action item would you like to leave everyone with so that they can make a difference locally?
Ari, you want to start off?
Yeah, I think we've already hit the high points. I mean, I think most centers have pacemaker clinics, which we have nursing professionals that are part of the team. And what I've always tried to teach here is that we have a team approach to patient care, and it's not just it's from the person taking the phone call in the office to the nurse, to the physicians, to the fellows, and we've developed a team approach in taking care of the patients. We have an electronic record, but we got to use the electronic record. There's a little tab that says implant. We got to fill that out. How many times does patients come in? There's nothing there that they have an implant. So all of us have to work from the medical student to the nurse. We're all part of one team, and that's to develop the care to the patient and understand that, again, it's a lifelong risk. It's not just a post-op management.
Right. So I'd like to say this. First of all, I congratulate everybody that's on the webinar because you're staying informed. I think we're just becoming aware. Do you know that there are millions of implantable devices out there? Those millions of devices provide a chronic risk for these patients, a chronic opportunity for great care and better lives, but we need to manage that risk. And so stay informed. We have this national CIED infection initiative through the American Heart Association. You can watch the video that's referenced on the screen right now that talks about the seminar that we did. You can join in and look at some of the products that we're producing to help you work with your patients, work with your staff, work with the community. The question is, what can you do locally? Well, I think you start becoming aware. Measure your infection rates. Make sure that you're getting the antibiotics on board. Take a look at your aseptic techniques in your ORs and such like that. And look for opportunities to get engaged to help everybody do better with this case. We have a special online community for lead management called leadconnection.org. It's another way to do it. There'll be more webinars. There'll be more treatment. There's more research that's going on. There's a flood of information. There didn't used to be an understanding of how many infections there were or what the risks were, or what were the useless interventions and what were the good interventions. Now there's information. It's time to take action. Thank you.
Thank you, Dr. Wilkoff and Dr. Greenspon for leading today's webinar. For the audience, you will receive a follow-up email tomorrow with a survey on the presentation, and we will appreciate if you will complete the survey, provide your feedback. In that email, you will also receive a link to view a recording of today's presentation and a certificate of completion. Please be sure to check out the CIED Infection Initiative website, that is heart.org/treat to beat CIED infection. And that is heart.org/treat2beat CIED infection. You can find all the current and future education opportunities on that website. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.